It still shows off.
We started now. We're live.
Great. Hello, everyone. We hope that everybody is here, and I'm really excited today to open the discussion on our webinar that is titled Addressing Discrimination in Medical Education. My name is Ala Abu Sufyan. I am SCOME RA for Africa, and together with Idil Kina, who is Court Director, and Igli, who is the Liaison Officer for Reproductive Health and AIDS, we will be helping you today know more about discrimination and its implications in medical education. So stay tuned. We want this to be as interactive as possible. And so we have a Q&A section at the end of this webinar. Keep your questions and we hope you have fun. Idil?
Thank you so much for your introduction. Um, okay. Hello, everyone. So, thank you so much all for being here with us. This webinar is really important for both SCOME, SCORP, and SCORA altogether because it is such an important topic for us as medical education defines what sort of doctors that we are going to be in the future. How well medical education builds capacity in us regarding human rights and battling discrimination will also show that as doctors how well we will be able to do this. So I'm just going to start off by defining discrimination. Um, so this is a very simple slide and a very simple definition, therefore. Discrimination is the act to differentiate and separate. So just by looking at this, it doesn't sound so bad. And actually, it is not bad to differentiate and separate one thing from another. We do this with a lot of things in life. We do this with knowledge, we do this with nature, we do this in order to understand something. However, this differentiation and separation can also be used in order to maintain societal power structures. So when this happens, it becomes the unjust or prejudicial treatment of individuals or groups based on demographic characteristics they have. So what does this mean? This means, for example, unjust and prejudicial treatment of a person based on their gender, their sexual orientation, their race, their ethnicity, the religious group that they're in. So I also want to draw attention to these terms unjust and prejudicial, even though I cannot pronounce it. Unjust. So it reminds us the element of unfairness of this act of differentiating and separating. And the other word, which I cannot pronounce, gives us the idea that this process to act and differentiate includes stigmatization and false knowledge about this group of people. So based on these, we're going to dive further into this concept and how it is relevant to medical education. But right now, I'm going to define further about discrimination. Okay, so we said like in the previous slide, the act to differentiate and separate. But we're not talking here about incidental acts. We're talking about societal power structures that manifest into interpersonal, institutional, and structural levels. So what does this mean? This is about how our societies are built and how the power balance between the societal groups of people, the demographics, work and impact our lives. So discrimination can happen between one person to another in this interpersonal setting. It can happen within an institution and organization based on the culture of that organization and how the people there work. And it can also be structural, but regardless of which level it manifests at, it is based on this defined power structures of our society. Of course, like these power structures can be also universal, like universally defined, such as, for example, gender imbalance, but they can also differ from society to society based on which demographic group is stronger in that society. And here, for structural, I put a picture of a tree. in order for us to understand this, because we need to understand that, yes, like again, in this previous slide, the definition is very simple. However, in reality, discrimination is something that roots from our societies, and it's deeply rooted into the power balances and the cultural aspects that we have. And its roots like this. And I think this is a good metaphor, because if I zoomed into just one um petal of this tree, and if I asked you what this is, then you would just call it a leaf, or you would just call it a flower, but you wouldn't see the full tree. And I think when we address discrimination, this also happens very often, in the sense that we just saw an interpersonal communication and we say, oh, that person is just being rude that day, or that person is just being mean, or even, because discrimination can also be done in a very polite way, we can just say, oh, that person didn't mean that. But when we tackle discrimination, because of its structured nature, we have to actually try to see the bigger picture. And even though what is in front of our eyes is just the small leaves at the end of the branches, we need to remember that it's part of a bigger tree with big roots coming from the power balances of our society. Okay, so I'm going to dive into another concept called the hierarchy. So, um, hierarchy. Okay, so we just explained that how discrimination is not just something that happens incidental, and its roots from the societal power structures. And this is to explain that discrimination doesn't always also just happen based on one future of the person. And a person that is oppressed for one future can also oppress other people based on another future. And this is also something about what we call intersectionality. For example, I, as a woman, may be oppressed because of my gender, but I, as a member of the ethnic majority of my country, maybe act as an oppressor to the ethnic minorities. And hierarchy is a word to define the holistic uh, power balances in a society. So, for example, racial discrimination, ability based discrimination, gender based discrimination, sexual orientation based discrimination. Like it says in this slide, there are many structured power dynamics in our societies that cause discrimination, and with hierarchy, we are able to address these dynamics as a whole. And in the next slide, you will understand this better. So, this is adapted from Catherine Pauli Morgan's describing the Emperor's New Clothes, Three Myths of Educational Inequality. So this is a really good visual. Oops, sorry. This is a really nice visual. And it's about, so for example, um, here you say, okay, so here you say two ends of a spectrum. It's like heterosexual individuals and then LGBTQ individuals. And the power based oppressive system that define like that causes heterosexual people to discriminate against LGBTQ people is called heterosexism. Or for example, able-bodied people and persons with disabilities. So these persons with disabilities face discrimination or oppression within this power system called ableism. And again, like racism, uh, genderism, gender-based discrimination. So yeah, so hierarchy is something that defines all of this. But why am I explaining this? Is that this thing that, like this visual that you're seeing, um, again, I underline that this may not apply for every society around the world, but this set of logic, the logic behind the hierarchy applies to almost every society, because in almost every society, like in every society, we have our demographical features that we are aware of, and based on these features we have a distribution of power. So this is all about one group oppressing, or one group of individual oppressing the other in order to maintain the power in their hands. um, and again, this does not always, because we have more than one feature. This makes this whole situation more complicated. But why are we discussing this now? Like, how is this relevant to medical education? Is that this is something that we have in our societies, and medicine itself, even though it's a science, um, it's a science that is very much related to humans. It's the science of making humans, or like enabling humans to live healthy lives. And again, it is done by humans themselves. So medicine is not just the science of human biology. It's this multidisciplinary field that aims to achieve the health of a person. And health means social, physical, and psychological well-being. Um, and therefore, like, societal power structures and human rights issues we face are highly relevant to our health, and therefore medicine and medical education. So imagine this, like this again, in this visual, um, as future healthcare providers, as future doctors, as people who will maybe teach medicine in the future. Our main purpose would be to provide healthcare and make sure that people that we provide care for are able to live healthy lives. And whether they get to access this healthcare, or whether the healthcare will provide them is meaningful, is based on how much we are able to eliminate the discrimination that they face based on these power structures. So it's really important to understand us. This is one. And second thing is, what will, as we defined health as social and psychological well-being too, we cannot ignore that a person who will be discriminated and oppressed will not be healthy. Like, it's directly an indication of a person being unhealthy if they live non-dignified, like if they live a life under discrimination or oppression, or their basic human rights denied. So we need to have this awareness too. And also, lastly, it's important that, like I said a moment ago, medicine is conducted by humans, and as humans we are raised in the societies. So even though how nice or good people we are, we are taught these sort of power structures, taught into these power structures, and therefore we are also filled with this bias inside us. So we need to take this extra effort to acknowledge this bias, or whether we contribute to these power structures, and how we can undo that. So how is it relevant to medical education? Despite the importance of this human rights based understanding, as we explained, one, like I said, neither medicine nor medical education is immune from societal biases, and discrimination as medicine and medical education is conducted by the very people who were raised in the society. So it is a very, very dangerous thing to assume that just because, oh, we are going to be doctors, we won't violate human rights. Oh, we are medical students, we care for humans, human rights is not an issue. No, every field in life is open to be impacted by the structures of our society, and therefore these biases and discrimination, because these will exist and infiltrate everywhere unless they are specifically addressed and battled against. Because these things, these medical field, medical education, it's conducted by the same people who are raised in the society, and maybe the same people who benefit from these power structures. Like, because these people who are deemed privileged by the societal structures have greater access than the people who were being oppressed or discriminated against, and therefore they are the ones who are determining how things will go, or what's important and what's not. So therefore this is highly important to undermine. The second issue is, so this is something specific to medicine. um, like we just said in this slide, that medicine is not the science of human biology. like biology, human biology is really important in medicine, so that we understand the physiology of things and the pathology, and therefore we are able to give any realize physical health of people. However, limiting medical education to human biology is like limiting health to only its physical aspects. But I think something like, regardless of how unaware of their own biases or unaware of the importance of human rights, something that every experienced medical practitioner would agree is that health, like even physical problems, are not actually just physical problems. Social problems and psychological problems, they impact healthcare more than we would ever guess. Um, so the second point is like, therefore, but despite this, there's still the dominance of biological and mechanical approaches of healthcare. Like, regardless of this undeniable reality of importance of social and psychological well-being, we are like in medicine, unfortunately, we still tend to undermine the human health just to its biological aspect and treat the human as a machine that we need to fix. And this actually creates a problem that we define in the especially in the early stages of medical education. The educators are prone to define a norm human um, to medical students, so that it's easier for the medical students to understand how a healthy human should be like, and to pathologize or stigmatize every other characteristic that falls outside. And this is actually a very good reason that, despite how human oriented the practice of medicine is, we as medical students are also very prone to be discriminatory towards, for example, LGBT individuals, because for us, especially in the early stages of our medical education, what we face is there's a normal human defined for us, so that we are able to identify anything that falls out of that as a pathology. So we are very prone to have this mindset where we explain something different as a pathology and try to understand what's wrong with, like, between quotation marks of general statements of medical students, like what's wrong with the people who are outside of the norm human. um, and like the third problem is, human rights, even as a concept, are merely introduced adequately within medical education, and and this is actually one of the reasons that it is not prioritized by the ones who conduct medical education and build curriculums. So, for example, if medicine is dominated, like as a field, by the people who are deemed privileged according to our societal power structures, and if these are the people who determine how things will be, they will of course implement their own vision. And if they do not get their health impacted based on their human rights struggles, of course, human rights would be irrelevant. It would be an irrelevant topic to introduce to medical students. Another thing also is about this norm human thing. This doesn't just happen on a level of healthy human and everything else is a pathology aspect, but also, for example, the examples that given by medical educators, the patient profiles drawn by them can be tend to only limited to people who are the mainstream norm humans of their society. So, for example, I think this can be something that everyone resonates with. Like, for example, one thing I realized in my medical education, especially again in the early years, was in anatomy classes, we would always see like at least 70% of the models that were shown to us to describe any sort of anatomical aspect of a human would be a white male. Um, and this is actually also very problematic, which I will explain further. But it's also like an outcome of the societal power structures. Okay, so the problems in medical education, therefore, is shortcoming of capacitating medical students into providing non-discriminatory healthcare. So what does this mean? It means shortcoming in the sense of um, acknowledging shortcoming in the sense of capacitating a medical student to acknowledge and battle their own biases. That's one. Also, shortcoming in the sense of, for example, um, teaching a medical student to take a person's sexual history, but in a way that they could only do it to a heterosexual individual. So, for example, when they take medical history, they assume the patient's partner's gender, or for example, they ask questions in a way that do not include other ways of people engage in sexuality, therefore ending up losing data. Or, for example, again, this can also happen in the level of societal values, such as I think one thing that we face is that take again in taking sexual history of patients, doctors asking whether the patient is married or not and trying to figure out based on that if they're sexually active or not, instead of just asking in a more appropriate way if they're sexually active. Of course, there are like also cultural barriers regarding that too, but again, the first option is very, very, very actually misleading in a medical sense. Um, being also another problem is, so here what we discuss is if our medical education addresses discrimination enough, like throughout the survey. But unfortunately, another problem is medical education can sometimes be a perpetrator of discrimination. Like it can cause discrimination, as we explained. um, it can either be through educators biases and discriminatory examples. So like for example, unfortunately today, like some medical educators, like this is my personal experience, but I think some of you would able to be able to resonate again, can still use LGBTQ patients as an example when they're talking about sexually transmitted infections. And I'm not talking about medical educators providing correct statistics or anything like that. I'm talking about very setting these patient profiles as example of these situations in a stigmatizing way. So they can have very discriminatory examples. For example, they can have statements of examples that reinforce gender-based discrimination or gender roles and stuff like that. Another problem is that they can be a perpetrator of discrimination through teaching outdated and pseudoscientific data. Now, medicine is really advancing in the sense of getting a second look at a marginalized population and like depathologizing things that groups or aspects that have been wrongly pathologized. However, we do not have like adequate mechanisms to ensure that this correct knowledge now is being taught in medical schools. And still, I think many medical authorities, not authorities, but like still, we as medical students, we have a great role in this to keep up with this sort of data and make sure that we capacitate our educators in this sense. And I know it's easier said than done, but this is also a problem. And discrimination within medical education itself, thus bias. So again, in this survey, we did not address like the point of the survey was to see how discrimination is like taught to medical students in the curriculum, and also if the curriculum was inclusive, also like the learning environments. But then also there's this concept of discrimination within medical education. And even though this was not like one of the targets of the survey, um, it is a reason why our medical curriculum is not necessarily the most inclusive, because discrimination in medical education means that, again, like we said, people who are deemed privileged by the societal power structures have a greater saying in the content of medical education and scientific processes. Therefore, what comes out of these processes are also comes out according to their needs and biases. Again, another problem is not so jumping to that is the non-inclusive content, settling one demographic group as norm human and stigmatization of the other groups. So again, like the example I give, and this is actually something very important. I think like when you address this, you can be accused like in if you address any of these, you can be accused as being overly sensitive. But this is actually something really important to have like diverse examples within like within the medical materials. Like for example, um, it is a problem if the male anatomy is used um, in describing every pathology or teaching every anatomical system, and the female is only used when we are discussing female reproductive system and, for example, breasts. So this is a problem because this means female is secondary to male, female is additionally to male, and this is actually the first step to marginalization because male is defined as norm, so the needs and the diseases and the complaints of the male is also norm, and the complaints, diseases, needs of the female is coming secondary in addition and additionally, and this actually impacts. For example, one research was conducting CPR to women, and because of, for example, how female breasts are sexualized and how female anatomy is sexualized, in America, what they did, like this research, is that people are less prone to do CPR to female chest because of the lack of exposure that they get. Because for them, it's more sexual, whereas the male anatomy is normal human. Um, Shortcoming of capacitating medical students about the human rights aspect of the science of medicine. So again, this is a problem that we have, is that general knowledge of human rights and how human rights and discrimination oppression works and how it impacts actual health and access to healthcare of the patient. So this is the general problems in medical education. Um, so we're now going to go into the project itself. Again, like not everything I stated was necessarily in the scope of this project, but I thought re- providing the human rights perspective, they were very important to address so that we understand the purpose of initiating a project. Because as we said, like as was said throughout the past slides, um, it's really important to like the first step is to acknowledge and address. So by this survey, we're actually taking this by this project we're actually taking this first step. Anyways, I think I went slightly over time, but I just hope you enjoyed it, so I'm just going to give the mic to Allah.
Yes, no worries, Idil, and thank you so much for this elaborate explanation on discrimination. Based on what Idil has shared with us, IFMSA, particularly the Standing Committee on Medical Education, Rights and Peace, and Reproductive Health and AIDS, came together to work on a discrimination medical education project. Now, the main objective was to understand how medical education worldwide is addressing discrimination against vulnerable groups. So, the main question that we're trying to answer is, does our curriculum adequately prepare us as future healthcare professionals to tackle different forms of discrimination against vulnerable groups? And the secondary question that we also wanted to assess is, how inclusive is our teaching and learning environment to marginalized and vulnerable groups? The methodology that was used is that we launched this online survey on IFMSA platforms. The survey was based on a curriculum assessment tool. And this curriculum assessment tool has been developed by the Advocacy in Medical Curriculum Small Working Group. And this small working group has been collecting data on different ways that curriculum is being assessed, and they came up with this tool which is now piloted. It has 4 sections. First of all, the socio-demographic data. So we intended to collect some background on the participants, and then second stage, or the second component, is curriculum assessment. So here we're assessing different aspects of curriculum that include teaching and learning methodologies, educational strategies, assessment and evaluation. The third component of the survey was learning environment, which is very important for us in this topic because, like we said, we also want to assess the degree of inclusiveness and cooperation in the learning environment of students. And the fourth and the final section of this survey was on student perceptions. So aside from that, we wanted to know, what do students really feel? What do they perceive about how this topic or how discrimination is being addressed in their curriculum? Next, so survey results. We had a very good number of responses, 174 responses from over 50 national member organizations or 50 countries around the world. Looking at the regional distribution, which is on the next slide, we have about almost 40% of responses coming from America's region. And then we have a 25% from Europe, 15% from Africa, and a combined 15% from Asia Pacific and EMR. Ivel, could you please turn the slide? Yes, good. So we can see that we have an overwhelming number of responses from the Americas and the European region, and we also have good representation from other regions. Next slide, which I feel is very important, is we asked this question: do you consider yourself to be one of the vulnerable groups? And a very significant number, 70% of participants who responded to our survey identified themselves as one of the vulnerable groups. So this throws in a very important perspective that even the demographic of students that are present in the medical educational system do identify as vulnerable groups. So discrimination is not something that they just should be taught for the sake of patients, but for the sake of themselves as well. So of course, a large majority were women, but we also had around 10% identifying as LGBTQ. Also 30% did not identify as vulnerable groups. Now I will move on to share the next set of results that are basically going to be around curriculum structure and which are very interesting. Bear with us a little. So the first question we asked was, when addressing vulnerable groups and discrimination in medical education, which areas are included in your medical curriculum and at what stage? So basically we wanted to know if the vulnerable groups were addressed in curriculum and at what stage. I'm going to first of all introduce the vulnerable groups that we assessed. First was migrants and refugees, people with disabilities, women, racial and ethnic minorities, religious minorities, LGBTQI, non-conforming gender identity, and finally people living with HIV. So this gives us a total count of 8 groups. Now, most of the students chose that this topic is not addressed in the curriculum, if you can see the purple bars. And we can see that the purple bars are significantly higher for 3 or 4 types of groups, which are the LGBTQI, non-conforming gender identity, racial and ethnic minorities, migrants, and refugees. So basically, this means that almost all participants felt that these 4 groups were rarely addressed in their curriculum. Luckily enough, the people with disabilities, women, racial and ethnic minorities, and people living with HIV are to some extent addressed in curriculum, but of course, it's not really conclusive. So looking at our next set of results, on the next slide, we have our question that says, considering the general approach to vulnerable groups and discrimination, what kind of teaching methods are used in your school's medical curriculum? So we wanted to see basically how students are being taught about discrimination. We had an overwhelming clear number of responses that pointed out that lectures are the leading method at 66%, followed by small group learning, which is problem-based learning, and to some extent clinical tutorials. Now, I would like to draw to your attention that these are the most prevalent forms of teaching and learning methodologies in schools. So this could also be a point of influential bias, where the fact that participants were selecting these just because these were the types of methodologies that are commonly used. And this brings us to an important point, which means that there is no specific or preferred teaching methodology that schools are using to address discrimination. Our next slide, okay, will be basically okay, on assessment. So the question is, considering the general approach on vulnerable groups and discrimination, what kind of assessment methods are being used in your medical curriculum? Again, we had the most common type of assessment being written assessments or multiple choice, which, like I said, is because most of the time the most common type of assessment in medical schools is written assessment or multiple choice questions. But we also had almost around 30% saying oral examinations and clinical examinations. What I found really surprising about this, and I'm going to throw in some personal perspective here, is that the way discrimination or the way vulnerable groups was being assessed was in a route or in a scientific concrete method. So it really shows that there's no specific type of assessment that has been used or implemented in schools for people to assess how good students are dealing with discrimination. So for example, we didn't find responses that said we have a certain station or we have project-based assessment. Actually, reports and drafts are at 6%. So this shows that there is rarely an individual form of assessment for discrimination. I'm going to quickly summarize the summary of this section, or what we came out of from the curriculum structure. So number one, most topics regarding vulnerable groups and discrimination are not addressed in curricula. And looking at the demographics of the 21st century and the healthcare workforce competencies required, this is really alarming. The second summary is the general approach in teaching methods is lectures like we established, followed by small group learning. And the main approaches in assessment are written exams at 47%, clinical exams at 29%, and oral at 27%. Moving next, we will have survey results reflecting the learning environment. And just so that you don't get bored, Idil will take over from here.
Thank you so much. If only I can manage my screen. Thank you so much for sharing. I think it's like the results of the survey, and especially for me, it's the part that impacted me the most was the first part, how it shows that how these issues are actually very much addressed in the curriculum is something that we need to pay a lot of attention to. So this is about the learning environment. Um, so it's about inclusiveness of, so for example, curriculum is about the content that is like designed um, in general, that is structured, but like this learning environment is about how we have these, it's something that includes not just like the group setting, but for example, our peers, our educator, the approach of our educator, like the personal approach of our educator, the examples that are given by our educator, partially the hidden part of our curriculum. Allah, feel free to intervene as anytime you want to add something. So we first rated this in the terms of its inclusiveness. So how much are these populations are included in this learning environment, whether through, for example, through examples, through their participation, and what we saw is, again, in a very similar way of how much they are included in the curriculum. Again, in LGBTQI plus individuals and non-conforming gender identities, we saw that the learning environment, according to our participants, was actually very dismissive. Things seem like, according to our participants, things seems better for people living with HIV, which is sort of understandable in the sense that how much of advocacy effort has been put regarding this issue in the regarding this in the past, and how much like through both updated medical data, but also through the fight towards stigmatization, discrimination, how much the medical perspective has changed towards people living with HIV, and how the importance of the societal aspect of this issue are now included in our medical education. Um, Again, women as a minority group, it was deemed more inclusive or above three. Um, People with disabilities, three was the highest number of inclusiveness. But again, for LGBTQI plus individuals and non-conforming gender identities, um, our participants deemed that the learning environment was highly dismissive. And I think like many of the people who are watching us right now can would, based on their personal experience, could agree on this, that even like from the approach that we see in our peer groups or our learning groups to the approaches of our medical education educators, from including LGBTQ individuals into general examples, general patient examples, to actually addressing the specific issues that they face. Our learning environment is highly dismissive, and this is actually, I think, a great reflection of the societal discrimination and stigmatization that they face. Yeah. Um, so we also rated in the terms of cooperation. And what we did was, in cooperation, it was about how much of their perspective was taken into consideration, and how, just like the learning environment, how cooperative it was towards these groups. And here what we say, what we have, like different from the previous slide, is that an increase of lower ratings, ratings, especially in when it comes to migrants and refugees. And this is about, I think, in some sense, an actual involvement of the vulnerable population into the learning environment, and thus the cooperativeness. And again, like in a very similar way, religious minorities, LGBTQI plus individuals, not persons with non-conforming gender identity, they face the same struggle in the sense that they face in regarding inclusiveness. Another thing that we assessed was the how accepting the learning environment is when it comes to receiving and applying feedback from the students. So now, I was also checking out the questions that we saw, that was in the live chat, and that was the reason I kind of missed out on skipping some slides. So sorry for that. But one of the participants asked how this could be implemented in medical education as materials to be taught, like regarding implementing what discrimination is and human rights. So feedback is a really important aspect of medical education, and this can be ignored. I think in many institutions or forgotten, but actually, as we said in the beginning of this webinar, medical education is the number one aspect of what sort of medical practitioners we will be. It will define who we are, as our profession defines um, our passions and what sort of individual we are and what we will do with our lives. So medical education has a great saying on who we are, or how will we turn out. So therefore, our involvement in what sort of education that we get and what will this education include is our biggest right. Like the to be involved as is our biggest right, but also our involvement is highly important, and therefore feedback is a very key aspect in medical education. Um, so what we also asked is that how welcoming feedback, welcoming the learning environment is. in regards of feedback from applying the feedback from the students, receiving and applying. So because, and this was also something I can provide input on based on my personal experience. I think one of the biggest problems we face in this context is that um, one, there can be this lack of awareness among students and educators in general about the importance of these issues or the harm of some things that we do. But then there's this issue that even though one person is very knowledgeable or very aware of these situations, when that person raises their voice in the most respectful way towards this medical education educator or the peer group or any other actor of this learning environment, they can face actually great backlash because again, there's this thing about medical education which is also a strength as much as it can be a weakness, is that we have this culture of and again, this sort of like leads to discrimination within medical education, and I do not want to swift to that way in order to not lose focus. But we have this culture of strong student and mentor relationship, where we have our mentors guide us with all the knowledge they have, and we just like try to receive from them as much as we can. But as much as this is like a weakness, this can be a strength. It can be also a weakness in a sense that, especially in more, I don't know, maybe conservative. I don't want to say conservative, but let's go with that. Conservative societies or more rigid,
Rigid.
where this mentoring culture is more rigid. Yeah. Sorry, am I going too over time?
No, no, I was saying in more rigid societies.
Yeah, rigid. Yeah, thanks. Yeah, in more rigid, in societies where this mentor relationship is more rigid, this can be something that you face great backlash if you provide some sort of feedback to the educator or the learning environment, especially if it's about a topic that is, for example, again with LGBTQ individuals or non-conforming individuals with non-conforming gender identity. If these are populations that are highly marginalized and stigmatized by that society, you can face great backlash. So, and this is the number one obstacle about uh, between you and you leading change within your medical education. So this is what we assessed here. That was a very long introduction, but sorry, I just think that it's really important. So what we come across is that we had this non-available option, meaning that the participants never tried to, uh, never was in the situation to provide this feedback. However, again regarding acceptiveness, you see that we do not have like, maybe women can be considered, but other than women we do not have like an option, a minority group where five is necessarily the dominant, um, okay, people living with HIV, but five is necessarily the most dominant aspect. So we can say that receiving feedback is and accepting and applying feedback is an issue, and especially it's an issue when it comes to LGBTQI plus individuals and individuals of non-conforming gender identity. Again, with migrants and refugees, the ratings like 3 and 1 was also really high. With women, 5 is high. Um, People living with HIV, 5 is high. And again, I highly believe that if Egle could join us now, maybe she could provide better insight on this. But this is like sort of the impact of the great work and advocacy that is done, and it shows that how it can actually impact, like this awareness can impact the approach of medical education and the educators uh, towards this group, because you will face a lot of dismissiveness and, like I said, backlash when you raise these issues up, especially due to the reasons that we defined in the beginning of this webinar. But in the long term, once you raise awareness in the general public among students, and once you create that student demand and come with that feedback to your educators and to your schools, based on the learning environment and to the curriculum, change will happen at the end, within the field of medicine, within the field of medical education. Okay, so um, accuracy. So this was also something really important that we address, how accurate the learning environment is. And this was because, again, inclusiveness, it's important. Like, it's important to include these groups within the learning environment, through the examples of the educator, um, through the case studies that we have, just through as a general approach. But it's also important to ensure that while we do this, while we are inclusive and cooperative, we're also accurate. So we're not stigmatizing anyone, we're not spreading any false information, we're not spreading prejudice. Because, as we defined in the very beginning, discrimination is this unjust and prejudicial. Um, yes, my international team already made fun of me, fun of my inability to pronounce this word, so I will not try it any further. But in order to avoid this, we also had to rate the accuracy. So, for example, also when we stated that the inaccurate and pseudoscientific data in medical still can spread through medical education and learning environment. So we wanted to rate this accuracy. And again, like, sadly, we said, okay, non in a non-sadly way, people with disabilities and women, they had higher ratings when it came to accuracy. And this is also something about, again, how inclusive our learning environment is towards these individuals, is because within medical fields we are more prone to address the specific issues of these individuals in a more correct way. However, when we, again, people living with HIV, um, there in the past there was great misinformation about this, about HIV itself, about the syndrome, if untreated, can be caused. I try to avoid saying something wrong about this. So, um, but yeah, we had a lot of misinformation about this in the past, and through, again, the efforts of advocacy groups and scientists, this has changed. And according to our participants, this vulnerable group at a high rating of accurate representation. Again, this does not indicate that these groups do not face any problems. They still face stigmatization, discrimination, and still, unfortunately, inaccurate and false approaches. But this was something that students at least realized. But again, LGBTQI individuals and non-conforming gender identity, individuals of non-conforming gender identity, they still face inaccurate information. And considering, again, my personal experience, um, I believe I've been in great learning environments with great educators who had accurate information. But one thing that we faced was, like, and I had a higher number of great learning environments and great educators that were trying to be super inclusive and cooperative with very good intentions. But again, these two populations, due to how marginalized they are and how the lack of mainstream representation that they have, misinformation, like, they can misinformation about the health problems that these individuals can face, or just misinformation about their own demographics, can be very prevalent even among inclusive and cooperative learning environments. And this was based on my personal experience, something I faced. And this creates another challenge because, for example, if the medical educator uses their initiative to include this group, and they try to create a positive impact through their inclusiveness, but they do it in a misinforming way, then the message, the feedback they receive from you regarding how they have been misinforming people can be very confusing and hard to tackle for them, because at the end they were trying to do something good. So yeah, that's also another challenge. Okay, and oh, sorry. And again, just to like some personal comments that was add. So the center comment, I think it's a really good summary that it isn't based on teaching students about discrimination at all. Um, and I do not find this hard to believe. Unfortunately, like we said, we can highly underestimate and ignore the impact of discrimination, oppression, human rights, and the relevance to these to health and medicine, and therefore we do not focus on teaching this at all. Um, Another comment, it's usually infringed with religion and a closed mindset with ethnic and religious, oh no, this word, prejudices due to lack of education. Sad to see medical students themselves belonging from such backgrounds. Um, so this actually as a comment is like underlines something really important that we also underlined in this presentation, in this webinar, is that with religion and closed mind. But what the two things that are said here, and ethnic and religious stigma, also these are all societal things. So what the commenter is stating here is that the problems within the society is infiltrating the medical education itself. So medical education is not immune from that. So this is something that we should also always remind ourselves, and we should never have this ego and or arrogance of, oh, we are already medical students, we are already doctors, we know the best. No, we are highly impacted by the societal biases and the societal issues that we that are prevalent in our society. I said society a lot, but yeah. So the fact that my university is a Catholic one severely restrains the topics we can cover and the way they must be talked about. Demographic minorities are touched upon as an afterthought or a coincidence. When reviewing a case report, the patients can belong to these groups, but they weren't chosen because of it. And certain groups are covered, but merely because they suffer diseases that they consider are under what medicine should cover. Okay, so this is actually again a very elaborate and very it's a very great comment, because there's just so many layers into it. So again, something societal. We're saying that restraining the topics that we can cover and the way that they must be talked about. Um, and it says demographic minorities are touched upon as an afterthought or a coincidence. So what we stated here is again the defining medicine through a norm human, which is the mainstream individual of that society, who is probably heterosexual, cisgendered men, um, who is a part of the main ethnic group of that society. So, and the other the minorities are touched as an afterthought or coincidence. So coincidentally they can be mentioned or as an afterthought, and this is something very dangerous, because when they're taught this way, when they're taught as an afterthought, like when you learn about this as they're like an annex or an addition to the norm human, then like we said, you treat their healthcare problems as an annex or an addition to the norm human. So you prioritize them, like you deprioritize their health issues, because what comes with the norm human comes out as a necessity because there's something wrong with the normal. However, the healthcare problem of the minority then comes um, as something additional that you do not take as much as seriously. So this is like how does this manifest is, for example, us taking the chest pain of women less seriously, and therefore, yeah, leading the underdiagnosis of, for example, cardiac disorders in women, or black women, for example, getting less like inadequate care in labor when they're in labor compared to white women in, for example, in the U.S. And this is like actually a great issue because their like their symptoms and complaints are can be often disregarded. And I'm not saying like, and this is not happening because doctors or healthcare providers are evil or they don't care, but it's just how the mindset is created. So again, continuing with this comment is when reviewing a case report, the patients can belong to this group, but they weren't chosen because of it. So inclusive inclusiveness is not something planned, as they say. And certain groups are covered, but merely because they suffer diseases they consider under what medicine should cover. And again, this is something really important: is when we are being inclusive. Um, yes, we should address the specific healthcare problems of these minorities, but we should also ensure that minorities are not just mentioned under these specific healthcare problems, and they are mentioned adequately as we are talking about general healthcare problems too, in order to not stigmatize. Okay, so I'm again leaving the floor for Allah, and thank you for bearing with me.
Thank you so much, Idil. I just also had a comment to throw on the previous slide, just as an addition. A lot of times when we tend to look at discriminated or marginalized groups like people living with HIV/AIDS or like migrants and refugees, we view them as biological entities of disease, and rather we don't see them as the full social picture. So instead of just learning about migrants and refugees on the move, why not make sure the curricula exposes us to this type of groups in such a way that we're comprehensive of everything that is related to their background? So, for example, teaching about migrants and refugees should not only be about diseases in them, but also about the backgrounds, their social prospects, and how they can affect. I mean, you can have a patient who is a refugee and who could be experiencing PTSD, but presenting with somatic symptoms. And because you're taught to take the biological approach, you disregard that. So I feel like a lot of times it's very important that we look holistically at these vulnerable groups rather than entities. So that was a really good comment. Moving on to survey results and student perceptions. I'm a big believer that students always see things a different way. Funny thing is, it's coming from a student, so I hope this is not a bias, but we always tend to see things differently because we're on the receiving end of education. So we had a few questions that we felt that we wanted to see what students think. And the first question was, are you satisfied with your current medical school's approach to vulnerable groups and discrimination, considering curriculum and learning environment? I drew this red line at roughly 50, and almost all of the groups and all of the participants felt that they were not satisfied by the degree to which curriculum was approaching vulnerable groups and discrimination. And this sends a very strong message and a very strong stance that something needs to be done about this. On the next slide, we have our next question, okay, that says, at what stage of your school's medical curriculum would be most relevant to address vulnerable groups and discrimination? So we basically here wanted to see where students felt they were comfortable enough to start learning about these vulnerable groups. Interestingly, we can see that there are a lot of the yellow bars are shooting, and yellow is spread throughout the entire curriculum. And I was really pleased when I saw this because thinking simplistically, we would see that students might say, okay, I want to be exposed to them in my clinical rotations. But luckily enough, everybody believes that, or okay, not everybody, but most people believe that this should be spread through the entire curriculum. So basically, we should not marginalize education about discrimination and marginalized groups in a certain part of curriculum, but make sure that they're always there at all levels. So when we're talking about infectious diseases, we never forget to talk about infectious diseases in migrants and refugees, infectious diseases in people living with HIV, infectious diseases in LGBTQI. So the point is, a lot of students feel that it should be spread throughout the entire curriculum. And my personal comment on this is that this is true because, like we have pointed out previously, a lot of things about discrimination are societally influenced, and it's very easy to add knowledge, but it's really difficult to change attitude. So, ensuring that our exposure to vulnerable groups and marginalized people is spread throughout the entire curriculum makes sure that we are allowing the student room to get comfortable and break through the norms that society has placed, and be able to address these groups when they meet them in healthcare. So, the next slide has a few of student perceptions. And the question was, why would you find these areas irrelevant to medical curriculum? So in the previous slide, we saw that some people felt that some things were irrelevant. I mean, we do have blue bars there at migrants and refugees. We also have a green bars at non-confirming gender identity, LGBTQI. So we asked the question, why would you find these areas irrelevant to your curriculum? Our first response was, my country doesn't have these communities. I'm going to go through all the responses and then give you an overall idea. The second response was, currently these issues have not been posed a problem in my medical school or the country. The third comment, which is actually, I think, really good, is regarding women. I do not think that in my country, a positive and non-discriminating behavior on the part of instructors and a generally positive non-discriminating environment in the university or hospital is what is needed, rather than a separate topic. So what this person was trying to say is that they do not think that they need to have a separate topic on this, but rather they need to encourage positive and non-discriminatory behavior. Now, my overall take on this is, a lot of times it's very important to acknowledge context. In medical education particularly, context is very important, because at the end of the day, education is oriented towards communities that we serve. But given that we are now in the 21st century and globalization is immense, and given that we as students are not training for today, but we're training for tomorrow, we're basically doctors of tomorrow, a lot of times, even if things are not very much relevant, they must be addressed. But of course, they should be addressed to a lesser extent. So for example, in Africa, it might be more important to address people living with HIV, because they form a larger demographic, so they get a larger bulk of attention in education. But that does not mean that we should disregard marginalized groups like LGBTQI just because they are not apparent in society. Because when we say that my country does not have these communities, it means you have not just been exposed to them, but they are definitely there. And what happens when you, as a doctor, work in another country? For example, I study in Sudan. We do not speak about LGBTQI. Nobody even mentions them. But what happens when, as a doctor, I work in the United States next year, or maybe after a few years, and I meet a person with LGBTQI, and I have to take some history from them. So we have to make sure that the education of today is addressing the problems of tomorrow and the context of tomorrow as much as it's addressing the context of today. So yes, this basically gave us a holistic overview of the survey results, and which we found really interesting. Now we're going to come to the actual walk the talk part, and which is the way forward and what action we can take. Idil, you can go forward here.
Thank you. Okay, we're going to now, like as Allah said, we're going to talk about the way forward and what action we can take. And I'm going to talk about some of the internal stuff that you can do. And Allah, feel free to join at any step, because I will give some of more like action principles based on human rights, but also like my own medical education experience. However, I would imagine that you have more knowledge on how medical students can participate in relevant decision making processes about the curricula and the learning environment. So please add to anything that I may say. um, okay, so the first step is and now I'm actually questioning if that's how you spell acknowledge, but I'm just going to go with it. But I think by being here, you already took this first step, is that human rights and medical education are undividable from each other based on the many reasons we said in this webinar. And therefore, the standing committees here in this project SCORA, SCORP, and SCOME was involved, but it doesn't have to be limited to that because we have very six well-functioning, well-structured standing committees that we orient our work around. Uh, they should collaborate and support each other. So this is very important that when you try to do an activity in SCOME in your national organization, try to involve the perspective of SCORP and SCORA or SCOF, or vice versa. When you do an activity, for example, in SCORP, when you do something about like patients' rights or something, try to involve the perspectives or understanding committees and achieve that multidisciplinary perspective. Um, so, but based on this collaboration, what you should have to do first be like through this webinar, even though this was not the topic of the project, because this was a predisposing factor, I discussed about discrimination within medical education. So you need to like who builds the curriculum and who assesses the education. So we need to have a call for diversity, um, because the answer to this, like who builds the curriculum and who assesses the education, the more diverse it is, the more of these populations are, or the allies, like, but good allies of these populations are involved, and thus these populations are represented in this process, the more inclusive the curriculum and the learning environment will be, and the more adequately this will be assessed. So what you can do is that, um, so we're talking about these vulnerable populations, and we also talked about like in the previous comments, someone indicated about this population does not exist in my country. Um, the thing is though, even though we may think that, probably like, and that's this is also a part of how people get marginalized, is that we assume just because we do not see them, we think that they do not exist. However, these, despite how marginalized these populations are, despite how society pushes them away, they're not actually far away. Despite everything, they're able to stand up and face these struggles and pass these obstacles and sit in the same desks that we do in that very class that we get our education. Um, so we do have fellow students from vulnerable populations, and probably the populations that you think that do not even exist in your country, but you do have, you like this, regardless of the oppression and discrimination, people make it somehow, and you will have, you most certainly have LGBTQ classmates, you definitely have women classmates, but you definitely have classmates with disabilities, even though they're not visible disabilities for you. You will have classmates with migrant or refugee background. So encourage them to participate in consultative meetings. So again, one person asked like how we can actually implement this change, is that like we said, feedback is really important in medical education, and therefore this is actually something that schools implement, is to get consultations from their own students about their learning environment and their curriculum, the content that they're receiving in general. So encourage these your students and encourage diversity in these meetings, encourage them to take part in this and make sure that their voice is heard. Encourage them to provide feedback through formal and informal channels. So remember about like the boring forms that your school asks you to fill after every exam, or like the questions that your educators ask about like the class, or any other feedback method. Um, Whenever a fellow student comes up to you about something that they're frustrated about or something that they struggle, encourage them to participate in these feedbacks, because this demand from this coming from the students is that would be the main leader of change. Encourage them to get involved in student organizations or other student bodies that have access, and encourage them to have a say. So, for example, in IFMSA, you have through your local committees and national organizations, you have great exposure to the chairs of your university, to the dean of your faculty, and you represent medical students, you have a voice there. Encourage these students to get involved in there and use these bodies. Encourage them to get involved in student representative elections, student councils in universities, and encourage them to be present and involved in educational settings. When the classroom an educator is facing is more diverse, there's a greater chance that that educator will take a look at their own content, even though maybe not once, maybe not in the second time, but throughout time. If your learning environment will be more diverse itself, it will be more inclusive by default. And raise awareness. So what we said, like this is such a vague thing, and I really hope it doesn't make you roll your eyes or anything when you see it. But it's really important because the demand should always come from medical students, and it should be a high demand. So you should raise awareness among students and also like the involved educators that how discrimination can be perpetrated by healthcare workers. So you should already raise this awareness about how human rights and discrimination are relevant, but you should also like make sure understand that healthcare workers can sometimes directly do discriminatory behaviors and make discriminatory statements. They can disregard complaints of individuals from vulnerable populations due to the reasons that we explained. They can have lack of knowledge about specific diseases and health problems impacting specific populations. They can do things that leads to the dehumanization of, and objectification of these vulnerable individuals from vulnerable population. So, as we said, we will practice what we learn, and that includes like what we learn. It also includes who we envision as our patients. So you need to raise awareness about among students on how inadequate education will impact the healthcare they will provide. So they will demand more, and they have you have to build capacity. So this is something again about, of course, I for myself maybe coming from a privileged point of view because um, again like providing feedback is always a struggle in any settings, but regardless of that, like other than that, at least in by the experience I got in my school, we had really good educators that were open to this capacity building, um, and a visionary medical education department. So this sort of like depends on how your school is right now, but it's also something that you can change through your own demand and advocacy. But building capacity in educators is really important. So why discrimination and human rights is important? They should learn that this how to create more inclusive classes, how to be more inclusive through their examples, through their practice, how to be more inclusive towards their students, how they can avoid being stigmatizing, and how to be scientifically accurate and socially sensitive at the same time. Many of the things that many people will say that, oh, for the sake of being socially sensitive, you're giving away science. But what will they present as science will be actually outdated pseudoscientific data or an oversimplification of a scientific phenomenon. Don't be afraid of science because science is actually like what is really scientifically out there is just out there. And what we're trying to do is take that and do something good for humans, for their well being. So don't be afraid of science, don't be afraid of knowing scientific data, and know that like scientific accuracy and social sensitivity are can be separate, but they're both important and they're not counterintuitive. So try to fix that narrative in educators. And how to reshape the curriculum. Okay, so this is a scary slide, but bear with me. Um, ensure updated medical data that doesn't over pathologize individuals. So avoiding stigmatization, avoiding scientific racism, sexism, heteronormativity. Ensure inclusive content and inclusive ways of delivering content. So when you advocate for reshaping the curriculum, this is how you do it in a human rights based way. So avoiding being the source of stigma and discrimination. So first of all, you shouldn't be the source of this. Like the healthcare provider should not be the source of stigma and discrimination. So you should address your own biases, and you should act in a human rights way, rights respectful way. Given giving diverse patient examples in every topic, like Allah said, actually, like not to tokenize vulnerable groups and not to limit their existence to the healthcare problems specific to them, but including them throughout is a holistic approach. Not limit again, like the next point, not limiting the inclusion of vulnerable groups to health issues specific for them, and addressing these health issues in a non-stigmatizing way. And this can be very tricky, and but it's really important. So content specific on human rights should be included, and how human rights are essential for health, specific healthcare related struggles of vulnerable populations. So we also, like, we mentioned health issues, which means diseases. But then there's also healthcare related struggles, which means like the discrimination they face in healthcare settings, um, how to identify and battle our own biases, and how to be an ally as future healthcare providers. So, like we said, like realizing human rights are really important. So we should also learn on how to be an ally. So, Allah, do you have something to add?
Yes,
Yeah,
I think I do have a few as well.
yeah,
So first of all, when we're now looking, I know in your mind you want to have exact actions that you can take,
yeah,
and my take on this is that you have to know the status quo in your medical school or in your environment. So what you can do is, for example, run a survey just like the one that we did, but only to your school, and then use that data, structure it in a very useful report, and then present that on your student board. In this way, you will be taking data from your actual context and then reflecting it on your student boards and advocating for more inclusive educational opportunities. And the second thing is, a lot of times curricula changes, as much as that we push for them, take a really long time. We all know that, because of the bureaucracy of our systems. So the second thing you can do is create your own space to be engaged with discriminated or vulnerable groups. So, of course, I know that, okay, this is from my LMO, and SCORP does have an activity where they go to refugee camps and hold health initiatives. So a lot of times, this is a way of creating awareness as well. You're creating awareness, you're advocating for a vulnerable or marginalized group, and you're exposing yourself to this group and interacting and learning from that interaction, which is what we call experiential learning, one of the best ways of learning. And all of that without actually having to change the system. So this is basically two ways. You either change the system, and while you're waiting for the system to change, you do your own magic and you expose yourself. This is basically my take on this. And just a small comment, please let us know in the comments if you think Idil should come to SCOME, because I'm totally convinced that she should now. Okay, Idil, please, the floor is yours.
oh, thank you. Like, thank you so much for saying that. Because at some point I was like, I have these recommendations, but I don't know if are they making sense in that SCOME perspective. But actually, a fun fact: in my first year, I joined IFMSA. I was a LOMI assistant. So, and I'm also the first IFMSA event I attended was a TMET. So I'm a TMET trainer. So I'm already there. Don't worry.
We're stealing you.
um, so the next part of our webinar is the action we can take externally. And I have just informed our LRA that she can join because apparently she has access now. But until she joins, I'm just going to share her notes with you because actually, like, I think because this is about medical education, and advocacy is a very core point of um, leading change and making impact. It's not like what we can do internal and what we can do externally are not two necessarily two divided and two separate things, because at the end, even though internally that we try to, like, my in my examples, we try to build capacity and stuff like that, but at the end you still have to reach out to some bodies and uh, conduct the message of the necessity of the change. So I'm just going to read through Egla's notes for you. Um, and what Egla wanted to share that, as you know, like key populations are a major topic in global health, and the stigma towards key populations drives active discrimination in virtually all sectors of society. So we said, as we said, and future as future healthcare workers, stigma. We see the stigma in our workplace, in medical students, and the communities. So the fear of facing discrimination drives the patients further away from accessing the services they need. And I think like this introduction, she provides us tell us how aligned the internal and external aspects of this issue. So she mentioned something about international decision making. So talking about international decision making, the United Nations 2030 agenda towards the Sustainable Development Goals goes with a slogan "Leaving no one behind." By adopting this agenda in 2015, all of the member states have committed towards this aim. Therefore, all people, regardless of their backgrounds, have rights to fulfill their potential in life and lead decent and rewarding lives, which is possible only in healthy environments. This means that goals and targets need to be met for all segments of society. Um, this year again, in World Health Assembly, these populations have been addressed a countless number of times, ranging from updates on global women's health strategy to the refugee health resolution to improving adolescent sexual and reproductive health. The phrase "leaving no one behind" is used in every other side event, and by now almost a must to use at least once in order to deliver a powerful speech. But what are the practical implications of the phrase? So again, she mentions about HIV and AIDS, which uh, which is actually resonating the focus of the survey, of the outcomes of the survey. Um, let's talk about HIV and AIDS. A major focus area in IFMSA is external work, and one of the three external goals of the SRHR global priority of this term. It is known that women are disproportionately affected by HIV because of certain vulnerabilities resulting from inequity, which are further accentuated by discrimination in healthcare. By merely being a young woman, your likelihood to acquire HIV increases double the time compared to young men. And these women are faced with double burden of discrimination because of their gender and serostatus, covering two of the populations we inquire. So, being a woman, like to recap, you get discriminated because you're a woman, and then because you're a person living with HIV. But also, a third aspect is that while trying to get healthcare because of your HIV status in the healthcare process, your access uh, to this healthcare can be undermined because that you're a woman. And discriminatory patterns in healthcare systems that essentially strive from the patterns in medical education we discuss a lot affect a wide range of services such as the efficacy of preventive strategies and the frequency of medical consultation in general. Studies conducted for the HIV stigma index revealed by example that a quarter of people living with HIV reported to have some form of discrimination in healthcare. So 20% of this population. It has also been shown that people who pursue high levels of HIV related stigma are 2.4 times more likely to delay enrollment in care until they're extremely ill. So, this is actually what states that how we can perpetrate discrimination and stigma and how this impacts um, the access to healthcare of people. So this is not just societal stigma. This is the stigma we are unable to battle. We were unable to battle within our healthcare settings. Um, to provide you with some examples faced of discriminatory situations, think about the denial of treatment and health services such as maternal care or family planning services. Think about the doctors making conscious decisions such as conducting unnecessary precaution procedures, which means isolating and minimizing contact with the patients. Often, the provision of antiretroviral therapy is made dependent on the use of contraception or the sexual behaviors of the person. This results in a vicious cycle. Um, oh wait, Egla is here.
Yes, I just didn't want to interrupt you.
Oh, sorry. Egla, would you like to continue?
If it's okay, however you prefer. Hello,
Um,
everyone, also.
you can continue. I think. Sorry, I was too caught up because I think you wrote such an amazing note.
Okay, thank you so much. So, as Adil mentioned, indeed, this results in a vicious circle. What does it mean? So, the care that is actually meant to be something that helps you becomes an overall impairment provided by the healthcare professionals. And this care actually leads to increased likelihood for the key populations to be exposed to the risk of the HIV transmission and to poor health outcomes for people that have acquired HIV, people living with HIV. So the end of AIDS cannot be reached by any ways unless this discrimination is adequately addressed and eliminated from all clinical settings. So from all of this, the main question is, do we as IFMSA can truly advocate on ending HIV and AIDS without addressing the roots of the discrimination which comes within from us, the medical schools, and the behavior norms that we are taught as the future doctors? Because it is clear that unless we tackle this discrimination against people living with HIV within the health systems, we will never have an effective response to HIV. So, all in all, when advocating as future healthcare professionals, we must highlight the fact that discrimination in healthcare, in many cases, derives straight for our everyday lives. And we must think of the ways this can be changed. And also, usually, the healthcare itself is addressed continuously as a major factor, adding to discrimination. The discrimination with the roots in medical education as the key solution is talked actually far less often. So basically, the best health related decisions on global level can only be attained if the stakeholders actually recognize the medical students as the very core of healthcare provision. The medical students that have to be aware of their responsibility in this issue and receive an education which is rights based, people centered, and most importantly, non stigmatizing. And this is the very message that we should communicate clearly when we speak out in international platforms and when we plan our interventions. However, the problem is that it is really hard for us to sound plausible when we don't have data on our hands. So, precisely this survey, the finalized survey with concrete case examples, will allow us to precisely showcase this data to our external partners. And in this way, we will be able to add more weight to our words when we speak up on behalf of 1.3 million medical students. And just one last note that I wanted to make is that we must also focus not only on showcasing these examples, but also on actually raising the voices of these populations that are mentioned in the survey, for example, women, and making them involved in the external representation to the extent that we are able to, which basically means ensuring the diversity and representation in our federation. Making sure that delegations that we actually send to the external events are gender I forget the word, are gender and regional representative. So that is more or less it from my part.
Thank you so much, Igwe. It's really great to hear about all the work that we could do externally. And I'm glad that Idil already said it. And basically, it's the slogan that is very important in today's time, leaving no one behind. Through this webinar, we hope to reflect how much the definition of discrimination, first of all, how much it is being addressed in curriculum. And we hope that through the survey results, you have come to see the gravity of this issue. And we hope that we have inspired you through actions that you can take on a local level, internally and also externally, to raise voices and advocate for this. Essentially, health is for all, and we must not leave anyone behind. So, yes, now we're open for your questions. Do we have any questions? So far, I see none on the live chat. You can text your questions in the live chat if you're there with us, and we will answer. Okay, this is either a really good sign or a bad one, but there are no questions yet. Idil and Igle, do you think we should wrap up and end now?
Um, wait, because I remember I saw two questions, but okay. So one question I saw was, but I feel like we address because I saw it before and we addressed it through the webinar was
Yeah, we addressed it
yeah,
before.
how could this be implemented? So I hope this is answered. If not, we can always like re open this discussion through social media. Um, Another question was, which is not necessarily something that the webinar addresses, but because I think it was asked because I gave it as an example. What is the proper way to ask about sexual activity while we are taking patient's history? Um, and Egle, do you want to answer this?
Honestly, I think it's a very broad question which can
Yeah.
hardly be answered in a few sentences. So I think it might be better that we forward some materials that are more precise because it's very broad.
Yes.
Yes, she's
Um,
right. I agree.
yeah, exactly. What's just like important is that it's not just about this like specific question, but also um, there is like um, while examining patient or taking patient history or just like communicating with the patient, acknowledging that the patient as a person, as a whole individual with their human rights and their own cultural background, rather than a set of organs or a machine with a specific disease. Like this human-based approach, um, and this sensitivity is really important. But also, of course, like specific answer would be through the materials that we can send. But just to address this and what we had addressed in this, to link this question to what we addressed in this webinar. And let's go till the end. No, okay. So hearts and nice stuff. Okay. Um,
Yeah, I just wanted to also
I
add
guess
to you,
that brings us
Idil,
to the
that
end.
no, I just wanted to add that the way Idil said it is very nice. The way you rounded it up is basically that we always have to strive for people-centered care, where the person is in the center rather than the disease.
thank you. Um, okay then.
Wiesz, ja brat chciałam zrobić ciągle zachód mył. Ja jestem
Do you have anything else to add?
pessoal e tivesse só que eu ia incluir, mas essa casa está a diferente.
I guess not.
None from my
Um,
side.
yeah.
Mas assim, mas depois
Allah, do
So
you have?
thank you so much. Yes, I have nothing more to add. Thank you so much for those who made it to this webinar. And we hope that this topic has been interesting to you. Please don't feel free to contact us if you want to hold any local initiative or need any more resources on this topic. And have a good evening. Thank you.